Thank you for joining this program. My name is Dr. Walt Whitley, and I'm an optometrist at Virginia Eye Consultants in Norfolk, Virginia. We're a tertiary referral care practice with all the various subspecialists, and my role in the practice is I'm the Director of Professional Education and Professional Relations. And as well, I oversee the dry eye clinic within the practice, making sure that all the docs, all the staff are all on the same page when it comes to addressing our patients' needs, getting patients ready for surgery, which we're going to discuss, but just making sure we're addressing both the comfort and quality of our patients' vision. Today, we're going to talk about MGD-associated dry disease, pathophysiology, current and emerging therapies for improved outcomes. Here are my disclosures, and we work with, and I work with various companies within the dry eye space. And one of the things that I do appreciate about this, it allows me to understand the science, understand what's coming in the pipeline, but also how is this going to benefit our patients, as well as both optometrists and ophthalmologists. So when we're looking at MGD, we know in dry eye, we know that this has been an exciting space within eye care. We know that there's been numerous developments over the last decade where at first it was dry eye, it was aqueous deficient, then there was inflammation, and then we learned more about MGD when the MGD report came out in 2011. Then 2017, we did have the dry eye workshop, the TFOS News 2, that gave us more information about dry eye and how this all fits together. And there's going to be more to come. And so that's what's so exciting. But when we learn about the role of MGD and how it affects our patients with dry eye disease, one of the things we're looking at, is we can see in this picture, is we do have ways that we can image the meibomian glands. And here you can see that both the lower lid and the upper lid has good gland structure, but that's only part of it. We need to look at, how many glands they have, or maybe how many glands they lost, and tell the patient, well, hey, this is where you are, and this is what we need to preserve. Or if they've lost numerous glands due to just the disease state itself, due to atrophy, letting our patients know that this concerns us, whether it's the lower lid or the upper lid, and what we need to do to help improve that, get them functioning better, but making sure that they don't get worse. So half of it's the structure, but the other half is going to be the function. Pressing on those glands, looking to see what type of secretions are coming out. Are they natural oils? Is it inspissated or like toothpaste, or is nothing coming out of those glands? And so, yes, that's part of the dry eye workup. We're going to have numerous tests that we'll talk about as well. But MGD has played a huge role in our patients with dry eye disease. And then we can come into the treatments. And here on bottom, this is just a video of that handheld thermal pulsation, where with this device, you can either take images of the meibomian gland, like the ones on top, or if you're doing treatments for the patients, you can show them this is the reason why we treated your glands and your disease, because we need to help open up these glands and help them to secrete better tears. And by showing them a video of the treatments that we provided, that Dr. Donenfeld will talk about, then patients are going to understand their disease state, get buy-in, and know that this is not just a one-time condition, but something that we need to manage over time. So what it comes down to, no matter what the patient's coming in for, whether it's glasses, whether it's contact lenses, whether it's for cataract surgery or refractive surgery, glaucoma, we can go on and on. We're all judged by the comfort and quality of our patient's vision. We know that 2/3 of the refractive power of the eye comes from the tear film corneal interface. And if we don't have an optimal surface, if there's any irregularities in that surface, we know that our patients are not going to have clear, comfortable vision. And so the tear film abnormalities result in significant reduction in the quality of vision and patient satisfaction. And due to this is the reason why we need to address the ocular surface, not just the cornea, but also the lids, where we know that that is the root cause of patients with dry eye disease. And so patients, the number one reason why patients come for a visit is for blurred vision. So tell me more. Is it always blurry? If it's always blurry, it may be refractive error. It may be cataracts or some other pathology. But if it changes or fluctuates throughout the day, then those are patients we know that does not have good tear film quality and may have some surface damage that's leading to their blurred vision. Other things we can ask the patients, and we can use the windshield analogy and to say, hey, is your vision always clear? Or is it like a windshield where it's clear, blurry, clear again with each blink? And if it does fluctuate like that, then telling the patients this is what we need to address. We need to help stabilize these tears to get you that clear, comfortable vision. Looking at the dry eye market, some of the recent data shows that there's over 44 million Americans that suffer from the symptoms of dry eye disease. You'll see other data points that maybe it's 30 million, 35 million. Unfortunately, half of those patients are diagnosed, and only about 10 to 12% of those patients have been prescribed a treatment option, a therapeutic treatment option for their disease state in a prescription. Looking at the cost itself, 3.8 billion spent on dry eye symptom relief annually in the US alone. There was a study by you several years ago looking at the average cost per dry eye patient from the payer's perspective, which is about $786 for a moderate patient with dry eye disease, whether it's due to the prescriptions and the treatments, whether it's due to the office visits, or whatever the reason that inhibited or that affected that patient that was suffering from the disease. But it's the most frequently encountered disease state by eye care practitioners, but it's an opportunity to help address an unmet need. Looking at, there's a paper that was published recently looking at the prevalence. In the Western states, it can be up to 2 to 20%, but we know in Asia, it can be up to 70% of patients that do suffer from dry eye disease and MGD. But by addressing it, we get better clinical outcomes for patients, increase patient retention and referrals, but also a way to grow our practice. What about quality of life? And where does MGD fit in, which once again is the root cause of dry eye disease? We know that from the quality of life standpoint, this impairs a patient's physical and mental well-being. We've seen patients that are suffering. We talk to our patients. Many of them don't understand why. And anytime we see the patients, what their condition is, why they have it, and what we're going to do about it and work with them to address their condition. Setting realistic expectations, letting our patient know that, this is going to be more a marathon and not a sprint. We're going to try to address their symptoms as quickly as possible. However, we're going to help them throughout their condition to minimize the impact that it has on their quality of life. Whether it's their hobbies, whether it's social activities, we know that it can decrease work productivity. And so Kelly Nichols, she published a paper, about 137 patients in the study. And what they found, there's about 30% decrease in work productivity due to presenteeism. So they're there, but they can't concentrate. They can't see, they can't read their computers and do those things that they need to do. Hobbies, we know for reading, APCIC did a study that you have a 30% decrease in reading speed if you have dry eye disease. And we know, many of our patients, that's part of their quality of life and things that they enjoy is to read their novels or whatever it may be. Patients have compared the impact of moderate to severe dry eye disease to that of a hip fracture or severe angina, and that was published by my partner, John Shepard. And so this does have an impact on our patients and the reason why we need to address our patient's condition. So MGD, this was in the 2011 paper that was published in the MGD report. Meibomian gland dysfunction is a chronic diffuse abnormality of the meibomian glands, commonly characterized by terminal duct obstruction and/or qualitative and quantitative changes in glandular secretion. It may result in alteration of the tear film symptoms of eye irritation, clinically apparent inflammation. However, we know that with MGD, it may not always have inflammation, especially in the earlier stages of the disease state, but then long-term ocular surface disease for our patients. If we go several years later, and this is 2017, the TFOS-DUES-2 definition. Dry eye is a multifactorial disease of the ocular surface characterized by loss of homeostasis, Symptoms, asking those patients, whether it's part of your protocol, whether you're asking the patient, whether your technician's asking the patient, whether you utilize a speed questionnaire, a DEQ-5, or perhaps OSDI. So identifying those symptoms, patients, when they realize that, hey, this is something that does affect me and we're addressing that, then patients are going to be relieved because they're like, my doctor's listening to me. My doctor hears that I've been suffering, and so they're going to help treat me. We get tear film instability that can lead to evaporation, that can lead to hyperosmolarity or increased salt concentration of the tears. That leads to the inflammation and damage and neurosensory abnormalities. And we're understanding the role of both neurotrophic keratitis, but also neuropathic corneal pain when it comes to patients with ocular surface disease. And so some of the call outs from the TFOS DOs too is anybody can get dry eye, whether they're young or whether they're more mature. We know that 80% of the time, there's going to be both evaporative component, but also aqueous deficient component. And so we do have to address both of those conditions for our patients. So let's start with the tear film and the importance of the healthy tear film. We know that there's over 2,000 components of the tear film, whether they're antimicrobial proteins, whether they're growth factors. We can see that and we understand the various layers of the tear film, whether it's the lipid, the aqueous layer, the mucin layer. This provides a smooth optical surface for normal vision. We know that it maintains the comfort for our patients, and it protects us from infection, environmental insults, and also maintains ocular surface epithelial health. And so we have our normal blinks, and we know the average blink rate's about 20 times per minute. However, we know in a dry eye state or due to evaporative stress, whether it's due to staring at a computer like I'm doing right now or reading a book, it can decrease about 4 to 7 times per minute, depending on what study you look at. But maintaining a healthy tear film is important for the comfort and quality of our patient's vision. Looking at the various layers, we know the lipid layer minimizes evaporation, helps tear film spread over the corneal surface. And so looking at the meibomian glands, what is the structure? What is the function? If we're not getting those clear oils coming out, if we're looking at the stability or instability with tear film breakup time or using objective tests, such as I look at homeostasis of the tears with osmolarity, then this is something that can affect the homeostasis. We know about the aqueous layer. That's majority of the tear film. It provides support for the ocular surface. And we know that in some patients, they do have a decrease in aqueous layer. Let's say it's going to be patients with Sjogren's or an autoimmune condition. However, this is something that we know many of the treatments that we'll talk about in a future section of this course that does increase the total tear, looking at the Schirmers. And then also the mucin layer coating the ocular surface epithelium. Functions as surfactant and allows the tears to wet the hydrophobic ocular surface and has the viscosity to help maintain that pure optical surface. Dry eye has an evaporative etiology, and so Michael Lentz data looking at 86% of all dry eye does have an evaporative component. And so making sure that we're addressing both, and that's once again one of the call outs for the TFOS DOs too, is that we're addressing both forms of dry eye, and that's the only way that we can fully address this for our patients. We've all had patients that we've had on various treatments in the past, and this was prior to understanding the role of MGD. And patients say, well, I've been on this treatment, why am I still symptomatic? And that's when we're learning, and there was various ways to detect MGD. There was various treatment options that were available that, yes, we know that the medications can help with part of the dry eye, but if we're not addressing the lids, if we're not addressing the biofilm, if we're not addressing the MGD, patients are still going to be suffering. Evaporative dry eye is multifactorial, whether it's due to loss of any of the layers of the tear film. We know cosmetics can affect that, telling our patients to make sure that they're removing their makeup on a consistent or every night, making sure that they're blinking. And we know that the blink rate, once again, each time we blink, the real lens muscle, the orbicularis, is helping to squeeze the meibum out from the meibomian glands and to help nourish that ocular surface. But either can lead to loss of homeostasis and evaporation. We've seen this slide, and yes, it's a busy slide, but it's a slide that really explains both the causes of dry disease. And let's focus on the right side, the evaporative dry eye, where yes, we have MGD, we have blepharitis, whether it's due to what's normal lid flora, what is abnormal lid flora, and we're learning more about blepharitis. Whether it's going to be staph, whether it's going to be due to Demodex, that can affect the ocular surface in the lids. That can lead to tear film instability and affect the lipid layer. We know other things that can affect it is vitamin A deficiency, different preservatives. We know preservatives are essentially a detergent on the ocular surface and can be detrimental to ocular surface, but also the meibomian glands. Looking at the evaporation, we have evaporation leads to the tear osmolarity. We're looking in that central circle here where we look in the center, activating the epithelial inflammatory mediators, leading to the inflammation, leading to the damage of the goblet cells and the mucin loss and the apoptosis. And that's a vicious cycle that keeps going. And that's partly from the right side, but then also the left side. The aqueous deficient, age, autoimmune, lacrimal obstruction, and things that we've been aware of for many years, but making sure we're addressing and identifying both to fully understand the condition, but also to treat the condition as well. Looking at the mechanism of disease, and this is a much simpler cycle to look at. And if we look at MGD and we think about the blepharitis and we think about the biofilm, and we've seen those patients that we're looking at the lids, and it's always important for us to look at those lids. Yes, we like to go to the cornea and the lens and the retina and the nerve, but it's important to first look at those lids because it affects the whole ocular system. We know that with the proliferation of the bacteria, that can lead to release of lipases and esterases. This increases the melting temperature of the meibomian glands or the meibum. That leads to the blockage and dropout and inflammation that affects the lipid layer, increases the evaporation, and this is the inner circle now, leading to inflammation, keratinization. And hyperkeratinization is what happens within meibomian gland dysfunction and something that we're trying to treat. So the lipids, as I mentioned, from meibomian glands are necessary for the ocular surface health and integrity. The blocked meibomian glands lead to dilation, atrophy, secretion, and eventually dropout for our patients, but something that we need to maintain to fully address patients with dry disease. And this is another slide that we're familiar with, looking at the pathology of obstructive MGD. And if we start on the left, and that's going to be a healthy meibomian gland, where on top we're going to see the excretory duct, where the lipids are going to be released. We have the central duct, the little tubes on the right. We have the acini and the ductules that we know that these are holocrine glands. And these holocrine glands are going to release the meibum and the lipids through the central duct, through the excretory duct onto the ocular surface. Going back to the muscle, the real lens muscle, the orbicularis muscle, that with that blink is going to help express that. But when we go to B to C to D and E, that's where we're getting the blockage, where that's where we're getting the hyperkeratinization that's leading to the blockup, that's leading to the atrophy that the patients may suffer from. When we look at the glands, we know that the upper lid has about 30 to 40 meibomian glands. The lower lid has about 20 to 30 meibomian glands. And so something we need to address. And so typically yes, we look at the lower lids, but should we be looking at the upper lids more to see the impact and the effect that that has on the ocular surface? Another schematic looking at how can we utilize the TFOS DUES-2 report and looking at a patient that presents to our clinic. If they're symptomatic, we're looking at with no signs, is that going to be a patient that has neuropathic corneal pain or symptoms without signs, and someone that we may be observing or talk about preventative therapy, telling them to blink more? If they're symptomatic with signs, then we're going to ask the various questions and try to identify, is this truly dry eye disease, or do they have something such as conjunctival chalasis, EBMD, or some type of ocular surface condition that may be affecting their eyes. And those are the easier patients because they're telling us they have a problem. So we're looking for the signs or lack thereof. But what about those asymptomatic patients on the left side? And if the patients are asymptomatic and they have signs, what do we tell them? We say, hey, yes, you've lost 50% of your glands. Well, well, so I don't notice anything. But that's where us being the provider and telling the patient, hey, this is what I see. This is my recommendation. This is a sequelae if we do not address that, whether it's due to neurotrophic conditions, whether it's due to some of the signs without symptoms, and addressing those patients. And that's often going to be our pre-surgical patients, where we know the data that patients came in. We'll talk about the FACO study from Bill Tratler. 136 patients came in for a cataract evaluation, and up to 80% of those patients had signs of dry eye disease, and what 63% of those patients had tear film breakup time less than 5 seconds. So they had the signs, but they weren't necessarily complaining about it. And so in the same study, only 22% of those patients had a diagnosis of dry eye disease. So there's a disconnect, and that's where we as eye care providers can do a better job of addressing that, not just to address the symptoms, but also improve the ocular surface, improve the biometry to give our patients the best vision after surgery. But then the asymptomatic patients that are normal, well, hey, no treatments required, just letting them know if you have any issues with your eyes, burning, stinging, make sure you let us know. Here's a way that we can go through our various protocols where we're asking questions. You can go through these questions in the red. You can ask simple questions. Do you have, yes or no? Do you have dry eyes? Yes or no? Are you bothered by red eyes? Yes or no? Does your vision change or fluctuate throughout the day? Yes or no? Or do you feel the need to use eye drops? Yes or no? Those patients say yes to any of those. Those are patients where we're either going to address at that visit, or let's say they're here for a vision exam, we're going to reappoint them for a follow-up medical visit to address their condition. Looking at the risk factors that we're going to talk about shortly, looking at the diagnostic signs, asking for symptoms on the screening, whether it's a DEQ-5, OSDI, you can use the speed questionnaire, but also looking at the diagnostic test, the tear film breakup time. We can look at osmolarity or surface staining for our patients. But then going to the right, 80% of the patients have both evaporative dry eye and aqueous deficient dry eye. So identifying that and addressing those accordingly. So who should we evaluate? We should evaluate everyone. Everyone has dry eye until proven otherwise, no matter what the patient's coming in for, because we are judged by the comfort and quality of our patient's vision. Symptomatic patients, having that protocol in place, utilizing the questions or questionnaires to identify those patients. In our practice, we utilize the speed questionnaire. Any patients that have a score of 6 or higher, those are patients we're either going to address then or bring them back for a dry eye follow-up. And whether it's going to be in my clinic, I have my retina partners, they may not, they will identify dry eye. They may not treat it, but they will still have the speed questionnaire available. If they score 6 or higher, their technicians will do tear osmolarity, looking at homeostasis of the tears and light scatter. And then they'll send those patients, refer those patients to one of the providers that address the dry eye. And then the retina specialists will keep doing their treatments, whether it's the injections or monitoring those patients. Contact lens patients, we'll look at some of the studies, whether it's that, whether it's other ocular diseases such as glaucoma. Systemic diseases, there's a study that 54% of patients with diabetes have dry eye disease. Looking at the medications, and a common question patient asks us, or why? Why do I have dry eye? Well, as we grow up, we wrinkle, we gray, we dry up, we get cataracts, or they may say, well, why do I have dry eye? And I'll say, well, you see these 10 medications that you take, these anti-whatever can exacerbate the dry eye disease, and something that helps the patient understand it's aging may be part of it, their body may be part of it, but things that they take can also contribute to dry eye disease. And so age, yes, we always think that it's going to be much more mature patients, but we are looking at studies, and there's studies available showing that the younger patients are presenting with signs and symptoms of dry eye disease, whether it's due to digital device use, whether it's due to changes in hormones. We know that the females typically have higher prevalence of dry eye disease than men, changes in hormones or lack thereof. We see the environment. We always talk about the environment that can contribute to this. I practice in Nevada where it's super dry. I practice in Virginia Beach now where it's pretty humid and there's dry eye everywhere. And so it does play a role. But something that we still need to look for all of our patients. The diet, we know that this can affect that, and we know various treatments and how we can help address dry eye with nutraceuticals is another way we can help our patients. We're familiar with the systemic conditions. I mentioned the ophthalmic surgery, the phaco study. Priya Gupta did a study as well looking at the preoperative evaluation of cataract patients. In her study, there was about 120 patients, and they looked at both tear film osmolarity as well as MMP9, looking at the increase of matrix metalloproteinases. And what they found is that there was a significant prevalence of patients that had at least one abnormal dry eye test, but 2 dry eye tests was found in many of those patients. And part of that was up to 80% of patients did suffer from that. Looking at more of the risk factors, contact lens considerations, and you can read these studies here, but this does accelerate MGD. And anytime we have our patients that are we're fitting for contact lenses or we're going to refit for contact lenses, making sure that they have the optimal ocular surface, but also the lids that contribute to the ocular surface to give them successful contact lens wear. Digital devices, and we know that this has definitely increased since post-COVID, but this is something that does affect all of us, whether it's the increased screen time, whether it's not blinking enough, and we know we can tell our patients the 20-20-20 rule, look 20 feet away, relax your eyes for 20 seconds, blink several times, help secrete some of those the meibum out to help address the condition. Glaucoma considerations. If you have a glaucoma practice, you have a dry eye practice. The more medications that you're on, the higher the symptom scores are going to be. And so in Fechner's study, the more medications the patients were on had a higher OSDI score, and so more symptomatic for dry eye. And once again, going to the preservatives, that it does act as a detergent. That does contribute to the ocular surface. And, how ocular surface disease affects our glaucoma patients, we know, well, if their eyes aren't feeling good, they're going to put medicine on the eye that's going to make it feel worse. If it makes it feel worse, they're less likely to use their medications. And so that decreases compliance for our patients. But we identify those patients by asking questions. We look at the risk factors. We utilize our tests. And so these have been the conventional tests over time. But as you can see, and actually it should only be the 87%, the 97% circled, that the highest positive predictive value for any of the dry eye tests, so you have a disease population doing tests to see, can this identify patients with dry eye disease, looking at inflammation, looking at osmolarity, which is the late changes of dry eye, right? Because we look at the tear film instability first, leads to evaporation, leads to the osmolarity, leads to the higher MMP9. And so this is late stage, but we need to catch our patients earlier. And so there's many different approaches, whether it's going to be the questionnaires, and there's just a couple right there, the OSDI and DEQ5, looking at the tear osmolarity or light scatter for our patients, the MMP9, and looking at the inflammation. We already talked about meibography, which is not going to be enough. So, many of you may have ways to image the meibomian glands, but if you don't, we have a transilluminator, and we can invert the lower lid to get a gross evaluation of the percentage of glands that the patient may have. Looking at those lashes, you can see my partner Liz Yu, there's one of her pictures, looking at the base of the lashes, looking at the blepharitis and the base of the lashes and the collarettes, with our pathognomonic of patients with dry eye disease. We know with Demodex, there's two species that live on the oculars or on the lids, and in the humans is going to be Demodex folliculorum, which is found in the follicle, but there's also Demodex brevis, which is found within the meibomian glands itself. And so addressing the Demodex blepharitis, and blepharitis is something that can help our patients. Whether it's the collarettes, whether it's the loss of lashes or misdirected lashes, that should be a clue to us that there's something going on with the lids and the lashes itself. Expressing the glands, what is it clear? Is it inspissated? We can see the cloudy clogged glands in that middle picture over there. Utilizing our stain, whether it's fluorescein, whether it's lissamine green stain, tear film breakup time, topography, corneal sensitivity, and lid seal measurements. Those are something else that I've added in the last couple of years to my dry workups. Anytime a patient has 2+ SPK or more, we're going to check for corneal sensitivity. I typically use my cotton wisp. Is it normal? Is it reduced, or is it absent? If it's reduced or absent, then I'm already thinking this patient has neurotrophic keratitis. Also look at the lid seal. When we ask our patients, when do your eyes bother you more? Is it morning or is it in the afternoon? If it bothers them more in the morning, one of the considerations we're going to have is going to be an incomplete lid seal, where doing the core Blackie light test, we can have them close their eyes, transilluminate the upper lid, and if we see any illumination below the lashes, then we can do our staining later. If we see any of this inferior staining, then what can we do to help improve that lid closure for our patients? And so just looking at the last years, and so looking at 2021, these were some of the tests that we had. The meibomian gland imaging. Mrs. Smith, this concerns me. You've lost 90% of your glands, and this is why I'm recommending this therapy, whether it's IPL, whether it's normal pulsation, or any type of expression. The osmolarity, objective measurements for our patients. And so this is just like we don't measure or treat glaucoma based on one reading. We're looking at this number over time, because the higher the number, the higher the likelihood it can lead to light scatter, which can lead to a blurred, interrupted vision for our patients. And so with this number, trying to get that patient below 308. And so, I'll do it the first evaluation. Follow up, no touch, and that because I don't want my technicians to put any fluoresce or anesthetic in the eye, and making sure the patient doesn't use any drops. But what is it at the follow-up? Is it 320 the first visit, 300 the next visit? Well, what's it going to be at the next visit? And so this is something that I do monitor, just like we monitor pressure for our patients. Looking at the lid parallel conjunctival folds that patients may have. In Europe, 70% of the time, they're utilizing this as a diagnostic test for patients with dry eye disease. The MMP9 on the bottom left, if you see a little pink, there's inflammation. And so that lets us know that we need to address it with an anti-inflammatory, whether it's going to be a steroid or an immunomodulator for our patients. Corneal topography. Let's say we're doing the cataract evaluation or contact lens evaluation. If there's any hot spots or cool spots for those patients, is that ectasia? What's going on with that cornea? Or is it a poor tear film? If they have any irregular rings on those placido rings, then we know that there's a abnormal tear film. But then looking at the numbers, right? We should have symmetric corneas, let's say average 43, 43 for both eyes. But if we have one eye that's 45 and one's at 43, we need to take a look. Is this a poor tear film? Address it in something that we can help with. And then anterior segment OCT, average tear meniscus height, 0.2 to 0.3. But if it's lower than that, then those patients may have aqueous deficient dry eye. But where are we now? So just in the last 3 years, we have some more innovations when it comes to treating patients or identifying patients with dry eye disease through diagnostic objective measures to monitor subjective symptoms that patients have. Whether it's going to be the left side where we're looking at lactoferrin. And so if the patient has low lactoferrin, that patient likely has aqueous deficient dry eye. But part of that test as well can also measure IgE and looking at allergies. So, and we know many times dry eye and allergies, does it burn or itch? What do patients say? They say both. And we say, well, pick one, and they're going to say both. And so this gives us a way to address or identify, is it allergy or is it aqueous deficient dry eye? The one in the top, the 338 that you see there, that's the Scout Pro, and that's measuring the light scatter or tear osmolarity for the patient and salt concentration. Handheld unit, so the technicians, they have it in their pocket. They take the number, but they can show that patient what their number is right in the exam room. The Brill aesthesiometer, when we're looking at patients with diffuse staining, 2+ SPK or higher, instead of saying normal, reduced, or absent corneal sensation, we can quantify it 1 through 5, and then having numbers to say, hey, are we getting improvement on center regimen or after using an amniotic membrane? The upper right, looking at epithelial mapping. If the epithelium is thinner on top than bottom, likely dry eye disease. But if it's thicker on top and thinner epithelium on bottom, then that patient may have ectasia. And so some other technology that we can utilize. And then on the bottom right, I don't have experience with this, but the omega-3 index test is another way to help monitor and diagnose and monitor our patients. The one on bottom where you see both the meibography and all the red, yellow, and green, that is some this is a diagnostic technology. This is the ocular surface analyzer. And so within 3 minutes, my technicians, before I come in the room, I have a speed questionnaire. I know their symptoms. I have an idea of the quantity of their meibomian glands, and so it gives me 30% loss or 20% loss. It can tell me the tear meniscus height. It gives me non-invasive tear film breakup time. It looks at the lipid layer as well. And so different ways that in 3 minutes, I have both the symptoms and the sign quantified for our patients. So it's an exciting time when it comes to the diagnostics of dry eye disease. But we have to take a step back and remember that everyone has dry eye until proven otherwise. The MGD, an evaporative dry eye, 86% of all dry eye has an evaporative etiology. And then utilizing the objective testing to both diagnose patients with the disease state, but measure improvement for our patients. With that, thank you all very much and appreciate you listening to this webinar.
Well, that was just an awesome overview of the diagnosis of MGD by Walt, and I really appreciated some new things that I learned there as well that I think will be very useful. So now that we've talked about the diagnosis of MGD, let's talk about real-world evidence and emerging treatments for the meibomian gland dysfunction. And this is probably the most common disease that you're going to see every day in clinical practice. So I do consult with a number of different companies that are in the MGD space. Let me start with a very simple statement, which I will stand by, and that is that MGD is the most common and arguably the most important diagnosis presented to the eye care professional. It impacts essentially every aspect of every patient day, and it is certainly the most common diagnosis that we see on a routine basis. So when you think of dry eye disease, just a reminder, when you're thinking about dry eye disease, as Walt just mentioned, 86% of dry eye disease has a meibomian gland dysfunction component to it. So don't forget the meibomian glands. And it's so common that we forget to look at the meibomian glands because they're right there. And sometimes we look right past the lids, looking at the cornea, looking at the cataract, checking the pressure, but don't forget to look at the eyelids. So there have been a variety of different studies that have been done that look at meibomian gland disease, and probably one of my favorite is TFOS, tear film and ocular surface, with the dry eye workshop. And that was really a landmark article that looked at meibomian gland disease. And they basically broke down MGD, meibomian gland dysfunction actually, into several different stages. And we'll talk about them all in a few moments. But essentially, they broke it down looking at signs and symptoms. Asymptomatic meibomian gland disease is extraordinarily common. As a matter of fact, a very simple rule to remember is that whatever your age is, that's the chance that you have meibomian gland disease. So if you're 30 years old, there's a 30% chance you have MGD. And for the average 70-year-old cataract patient coming in, 70% of them are going to have MGD. So there are very different levels of severity of MGD, and we'll be looking at them right now. And therapy is based on the level of disease. And you can see here, based on level 1, 2, 3, and 4, we have different therapeutic options available to us. So let's start by talking about level 1 MGD. Level 1 MGD, these patients are very commonly asymptomatic, but remember, no one presents with level 2 or 3 MGD without going through level 1. So just as you would want to treat a patient who had asymptomatic high pressures or asymptomatic high cholesterol, you want to treat level 1 MGD to prevent it from progressing further. And that involves patient education. And I'm a big believer in dietary changes. Our diet in the United States is way too dependent upon saturated fats. We need to have more omega-3s in our diet, and there are environmental changes as well. Eyelid hygiene plays a very significant role with simple warming or expression. And patients ask, well, why should I put hot compresses on my eyelid? Well, a normal meibomian gland patient will have a olive oil type of expression from their meibomian glands, and their oil glands are melting at room temperature. With meibomian gland dysfunction, our meibum becomes saturated fats that don't melt at body temperature. And that's why just raising the lid margin temperature just a few degrees is very effective at warming these clogged meibomian glands and expressing them. So I recommend that as a very easy homeopathic therapy for treating a very common disease. There are many systems for doing eyelid warming. Hot compresses done with a towel are certainly very easy. But one of the great lies that I've observed is that patients don't really very commonly actually perform the hot compresses that need to be performed. And by the way, I have a very favorite way of doing hot compresses if the patient doesn't want to do anything more aggressive. And that is, I have them put a small potato in the microwave for 4 or 5 minutes to get the potato nice and warm. I then wrap the potato in a moist washcloth that holds the heat, because heat is important, but moist heat is really the key to the hot compresses associated with MGD. And then they hold the potato wrapped in a washcloth against their eyelid for 5 minutes. And the heat stays there. They're not constantly putting the washcloth into water, wringing it out, having it drip down their face. So it's very comfortable. And then as a reward, when they're all done, they get to eat the hot potato, which gives them extra incentive to actually perform this therapy. But there are a lot of better therapies than the hot potato therapy. And these are interventional MGD treatments. There are a lot of them that are available. I like lid debridement. We'll talk about that in a few moments with microblepharitic exfoliation. We have semi-automated thermal pulsation, automated vector thermal pulsation, external heat and manual expression, and intense pulsed light. So let's look at lid debridement. Boy, if I had to say there was one therapy that I think is really terrific, underutilized, it's inexpensive and cost-effective, it's lid debridement with microblepharitic exfoliation. Our eyelids are moist surfaces. They're colonized by bacteria. These bacteria create biofilm, and the biofilm clogs the meibomian gland and prevents us from having access. Hot compresses don't get in, meibum doesn't get out. They become very inflamed. And the very simple act of doing lid debridement is really, I think, one of the linchpins to managing meibomian gland dysfunction effectively. As a matter of fact, it's my first line therapy for most patients. The analogy that I've heard many times, which I think is actually a perfect analogy, is that this is similar to going to the dental office and having your teeth cleaned. When you go to the dentist's office and you have your teeth cleaned, they're removing plaque from your teeth. And what is plaque? Plaque is biofilm. It's exactly identical to the biofilm you see on the lid margin in patients who have meibomian gland dysfunction. So this is a very effective way of removing contaminants and removing biofilm. And you can see how it's applied here. It just takes a matter of minutes. The device is inexpensive. You can use this on the upper and lower lids, and it's been shown to significantly improve symptoms as well as signs. And it needs to be repeated about every 4 to 6 months, just like having your teeth cleaned every 4 to 6 months. And you can't do this at home as effectively, but I find this a first-line therapy. And the bottom line here is microbial exfoliation makes everything else you do better. It makes topical medications better. It makes thermal pulsation better. So this is kind of the one therapy that I think is a very good starting place for managing MGD. Now, semi-automated thermal pulsation, this is from Alcon, is a LED that raises eyelid temperature and melts the blockages. You can view it through a magnifying lens. It's an 8 to 12 minute treatment, and it's been shown to vastly improve meibomian gland scores. It increases meibomian gland function by 300% at 4 weeks compared to baseline, based on several studies. And this is a very nice therapy. A similar therapy is more automated, and that is automated vector thermal pulsation. And this is a device that's applied to the lid margin that directly treats the obstruction. It heats the inner lid to 42.5 degrees centigrade. And things to remember are meibomian glands are much closer to the surface of the lid on the inner lid than the outer lid. So when we apply hot compresses externally, you're not really reaching the eyelid as effectively as applying them internally. The device protects the cornea and globe from heat. It's automated, and tear film breakup time has been shown to increase by 5 seconds to 7 seconds at 9 months, and it's been shown to last at least a year. So I do this once a year, and this is a wonderful therapy for patients with MGD. And finally, a third therapy for external heat and manual expression is shown here. This is a 12-minute thermal eyelid treatment in a prospective post-market center trial. It significantly improves signs and symptoms. The nice thing about this is that patients show marked relief, and they don't have to keep their eyes closed. They can actually keep their eyes open. It's very comfortable. And this study was done by our good friend, Paul Karpecki. Finally, when it comes to heating, we have intense pulse light, or IPL. And this was originally designed to treat the pustules of acne rosacea. It basically treats the telangiectatic vessels, and high intensity light is absorbed by the oxyhemoglobin in the superficial vessels, leading to coagulation and thrombosis, resulting in a reduced number of inflammatory cells. And IPL has been shown to improve tear film stability, meibomian gland functionality, and the subjective feeling of ocular dryness. And for patients who have rosacea, this is wonderful, because not only does it treat the eyelid margin, but cosmetically, it reduces the telangiectasia and the erythema that you see very commonly in these patients. So let's talk about level 2 MGD. In level 2, warming and expression is highly recommended. Patient education is important, and the very simple act about ambient humidity is very important. And for those of you who live in arid climates like Walt, when he was in Arizona, or me in the Northeast United States in winter when the heat is on, the very simple act of putting a humidifier in the bedroom can be a very therapeutic approach to a very common problem. And we spend about 1/3 to 1/2 of our lives in the bedroom. And again, applying humidity is a very simple way of making patients feel more comfortable. It's a little bit controversial, but there are many studies that show the advantage of omega-3 nutritional supplements. Some that show that it's not as effective, but there's really little downside to using omega-3s. And I find omega-3s to be very helpful in patients with meibomian gland disease. And this is recommended by the DEWS workshop. And I recommend and they recommend a gram a day of omega-3. Lubricants, lipid-based lubricants are particularly helpful. And I like to use transiently preserved or non-preserved tears. And there are so many good tears that are available today that have a lipid component to them that adds to the value, because you have to remember that in MGD, not only is the eye dry, it doesn't have either good quantity or good quality of lipid in the tear film. Finally, anti-inflammatory antibiotics, azithromycin and tetracycline derivatives are very, very effective in level 2 MGD. And topical azithromycin is wonderful. I don't find it as helpful as doxycycline orally, but for patients who don't want to be on chronic antibiotic orally, azithromycin can be a very effective therapy. It has a macrolide chain that reduces inflammation. And this is completely separate from the antibiotic component of these medications. So you're really using it for the anti-inflammatory, not the antibiotic effect. Again, all omega-3s are not the same. This is a paper by Alice Petropoulos and myself, among others, that showed that tear osmolarity actually decreases with oral omega-3s. Tear breakup time can increase significantly, and omega-3s can be improved. And there's something called the omega index, which actually shows the systemic absorption of omega-3. In this study, the ocular surface disease increased greater than 50% improvement over preoperatively, and the dose mattered. Here they recommended a little over 2,000 milligrams of EPA DHA. So for level 3 MGD, here the patients are very symptomatic. They have corneal staining. Their lives are being affected. Their vision can actually be decreased here. I always go to oral doxycycline here. And one of the most common mistakes that clinicians make is they use too much doxycycline. The normal doxycycline dose for infection is about 100 milligrams twice a day. You don't need that for the anti-inflammatory effect of MGD. And I recommend 50 milligrams twice a day for a week, and then go down to 50 milligrams once a day. And for some patients, you can even use 20 milligrams of oral doxycycline. I find it very effective. Vitamins can be effective in some of these patients. Cyclosporin has been shown to be effective here. Paper by Hank Perry and myself, and steroids as well. Short-term steroids really are such a wonderful therapy for this disease. They make the patient more comfortable, and they allow you to go on to more chronic therapies less symptomatically. Topical tears again, emollients, liposomal sprays, and again, topical azithromycin play a significant role here as well. When you get to level 4 MGD, these patients are extraordinarily symptomatic. Their vision has been compromised. Their quality of life has been decreased. And these patients almost always require anti-inflammatory therapy. Oral doxycycline, again, is highly recommended, but there are a lot of new therapies that are available. Cyclosporin and lifitegrast, while more attuned towards aqueous deficiency dry eye, definitely have an anti-inflammatory effect on meibomian gland disease. And we now have amniotic membranes, nerve growth factor with topical cenegermin, and amniotic membranes in eye drops, or actually in the amniotic membranes themselves. And these can be very, very helpful. Level 5, this has really become a surgical problem. These patients require aggressive anti-inflammatory therapy. You can use contact lens, and Walt, you have probably more experience than I do, but this is a good patient who may benefit from a scleral contact lens. And surgery includes punctal plugs, punctal occlusion, both temporary and permanent, as well as tarsorrhaphy in some of these very bad cases. A tarsorrhaphy can be a wonderful therapy in managing these patients. So now let's talk about new and emerging treatments for MGD, and there are so many of them that are coming out. One of my favorites is from a company called Azura, which is AZR MD-001, which is basically a drug that breaks down the secretions that block the meibomian glands. There's always hyperkeratinization in patients with MGD that block the glands. And this basically is similar to a dandruff shampoo, and it breaks the bonds between abnormal keratin proteins to soften the blockage. It slows the production of keratin, and it's just a drop, basically, or an ointment applied to the lids twice weekly. So it's twice a week, not twice a day. And it's been shown to be effective, and this is in phase 3 trials right now. Phase 2 trials showed a very significant improvement in symptoms, with up to 58% of patients becoming completely asymptomatic at 3 months, compared to 16% in the control group. Now, those are really good results for MGD. It's very easy to apply, increase in meibomian glands yielding liquid secretions, and a meaningful increase in meibomian lipid secretions compared to controls. All these p-values are very, very, very high, p less than 0.01. Some patients get a little burning and stinging, but otherwise it's been very well tolerated. Now I want to talk about something that wasn't approved for meibomian gland disease, but one of the happiest aspects of managing Demodex blepharitis has been that we've seen that a lot of these patients, and Walt, I'm sure you've seen this as well, these patients have really benefited from managing the Demodex. Demodex is an inflammatory organism. It's a mite that lives in the lid follicles, which is Demodex follicularum, or it lives in the meibomian glands themselves, which is Demodex brevis. It's very commonly seen in patients with blepharitis. Overgrowth causes mechanical irritation, chemical, digestive enzymes, and inflammation that can damage the meibomian glands. And in patients who I've been using this drug on for the last year, I've seen tremendous improvement in their meibomian gland scores as well. Demodex increases with age. No difference between men and women, no difference in socioeconomic status, and it's not related to lid hygiene. So this is not a disease of poor lid hygiene. It's just a common disease. And I think everyone has Demodex. The question is really how invasive it is. And the key we'll get to in a few moments is really just look at the lid margins. And that's been really a wonderful therapy. Look at collarettes. Collarettes are pathognomonic of MGD, and it's seen in very commonly in patients who have dry eye disease, with 59% of patients shown to have collarettes who had been diagnosed with dry eye disease. So it's very commonly seen in the general population, but specifically very common in dry eye disease. And it has a profound psychological impact on these patients because their eyes are always red and they're always irritated and they're always feeling foreign body. And treating them can really improve their quality of life, their quality of vision, as well as their cosmesis as well. Lotilaner is a therapy. It's been shown to eradicate Demodex mites and Demodex blepharitis. It's very well tolerated. It has no effect on mammalian cells. It only works by paralyzing the Demodex mites. You use it twice a day for 6 weeks, and it's been shown to be extremely well tolerated. And the results of the endpoints of the study show, again, complete collarette cure with p-values of less than 0.0001. Mite eradication is very high. Lipid erythema is markedly reduced. And these patients are extremely happy that you've actually made them feel better, but you've actually made them look better as well. Their eyes aren't red and irritated all the time. And the medication is, again, very well tolerated. Moving on to another recently approved drug, and that is Novo-3, which is Mibo, which is an inert and anhydrous semi-fluorinated alkane. It's perfluorohexyloctane. And this drug has a mechanism of action by interacting with the lipophilic component of the tear film. It basically stabilizes the tear film, penetrates the meibomian glands, and dissolves altered thick meibum. It's approved in the United States. It's also approved in other countries around the world, and it's been very effective. And actually, this has become one of my go-to therapies for patients who have meibomian gland disease. It really is well tolerated, and the incidence of negative symptomatology is less than 1%. Almost everyone benefits from it, and they benefit on the first few days of therapy. In the FDA trials, these patients were shown to have significant improvement as soon as 2 weeks. In the FDA trials, you saw here that patients who had tear breakup time of less than 5 seconds had dramatic improvement of efficacy, with benefits starting as early as 2 weeks, which is kind of what you want in a dry eye therapy. You want them to respond very quickly. In the phase 3 program, again, you saw the same thing with marked improvement in patients, and this was one of the largest studies of dry eye disease. And here you can see that corneal staining improved dramatically as soon as 2 weeks, as well as visual analog scores showing marked improvement in dry eye symptomatology. Key secondary endpoints were decreased corneal staining and visual analog scale showing improved dryness as well. Well tolerated, as I mentioned before. The patients had very few adverse events, with adverse events being really less than 2% for most patients. In conclusion, meibomian gland dysfunction is arguably the most common problem presenting to eye care professionals. It affects quality of vision, quality of life, and surgical results. It affects contact lens wear. There are a variety of new therapies that are now available, and there's a pipeline of new drugs that are approaching FDA approval, which will significantly improve our therapeutic options and patient satisfaction. And as meibomian gland disease is the most common reason why patients come into the optometrist and the ophthalmology office, being able to manage this common disease is really one of the key aspects to making patients happy and improving their quality of life. With that, I say thank you for spending time with me and watching real-world evidence and emerging treatments for meibomian gland dysfunction. And with that, let's have a little conversation with Walt and myself. And we'll start talking right now about some of these innovations and what we see as being important. So, Walt, you've done a great overview of how to diagnose MGD. I've talked about some of the therapeutics. Let's talk about real world in your office when a patient walks in for the first time with MGD. What do you look for, and what's your first line therapy?
That's a great question. And, this is something that whenever it comes to patients with MGD, oftentimes in my clinic, they're referred in. And so they've tried several different things already. And so it's important, as I mentioned when I started, is addressing both the MGD and the aqueous deficiency. So it's part of my dry eye evaluation where we have the questionnaire and the speed questionnaire. We do have the osmolarity that's already done for my patients, the MMP9. So I'm looking at the inflammation. But then the patient comes to me, there's not drops or anything put in the eye. And that's where I'm going to start from the lids, as you've mentioned before. Look at those lashes. Is there any stuff on those lashes or a biofilm? Looking at the glands, I had the meibography already, so I know where what percentage of glands they have, but I want to take a look at, what is coming out of those glands. And then I'll look at I'll look at the staining and go from there. So MGD, essentially, that's the first thing I have to look at, and that helps lead me to my treatment, where for a patient referred in for dry eye, you mentioned the heat, and so I prescribe heat. You mentioned nutraceuticals, so I prescribe nutraceuticals. I'm going to address something for the meibomian glands, and perfluorohexyl octate is something that has been my go-to for patients. If there's inflammation, I've learned that you still have to treat both. And so you may need the meibo, but you may still need an anti-inflammatory. So that's where I take a look at all those diagnostics. I use them to help develop my treatment plan. And then I'll follow up with them in 4 to 6 weeks. And so if there's MG involved, that's essentially how I address it. And if there's inflammation, that's what I do as well. What about you there, Eric?
I'm very similar to you, Walt, but I'm going to basically say, I love having meibography available to me, but as a clinician, you don't need to have meibography. You can diagnose MGD just by looking at the lids. And I think that's the key take-home message that I'd like to impart to those of you who are kind enough to listen to us here today. And that is, look at the lids. Look at the lid, and it will give you the diagnosis. And I think one of the really nice protocols that's been developed recently is the ASCRS preoperative algorithm. But it doesn't have to be pre-op, it can be for anyone. And that is look at the lids and literally spend 30 seconds. Look, lift, push, and pull. Look at the lids. When I'm looking at it, I'm looking at the meibomian glands. You can actually see if the glands are clogged. Look for those classic excrescences on the lids. Push on the lids and see if the meibum is expressed. And meibum will be expressed in different levels. It'll be hopefully olive oil, but it very rarely is. It can be a whitish type of a toothpaste-like material. And the most common finding I've seen is non-expression. You press on the meibomian gland and nothing comes out. I'd rather see toothpaste than seeing nothing come out. And that is how I stage my therapy based on pushing on the lids. I also want to have the patient look down, and I'm looking for Demodex, looking down at the lashes, and you'll see those classic collarettes of basically Demodex waste sitting on the lash margins. Then you want to look at lid positioning, and that's why I lift on the lid as well and see how it's positioned there. And that gives me such a good therapeutic decision-making tree. And I think the most common problem that we have, Walt, is that most patients are treated for dry eye with aqueous deficiency dry eye therapy, when, as you said so brilliantly, most commonly the reason the patients come in is because they have meibomian gland dysfunction. Now, very commonly they'll have both. They have both. I want to treat both diseases, and I treat them a little differently. So I'll treat meibomian gland dysfunction differently than I will aqueous deficiency dry eye, but make certain that you treat the patient with the right diagnosis. And patients come to see us all the time who've been on cyclosporin or lifitegrast, and they say they didn't get any improvement. And while these drugs are helpful for MGD, it's not their main function. They're mostly helpful for aqueous deficiency dry eye. So my starting therapy for these patients who walk in for the first time is hot compresses. And if they're not going to do hot compresses, I say use a mechanized system. That's number one. Number two, I like to use a tier that has lipid in it, and there's so many good ones that are out there. And number three, I like oral nutrition using omega-3s as well. That's kind of my starting therapy, and then I go on from there.
Yeah.
So tell me, Walt, what do you look for when you look at the lid margin?
So, having that patient look down, and so I was part of that prevalence study with the Demodex. And so I was surprised and looking at 180 consecutive patients within my practice to see how many patients had collarettes. As you mentioned, 58% of patients did have presence of collarettes and Demodex. And so that's what I found within my clinic as well. And so that was like, so that's been just part of my protocol, looking for any signs of Demodex for those patients. But going back to expressing those glands, it's only non-obvious, or it's only not obvious if you're not looking for the MGD. And as we discussed, 86% of patients, that have dry eye have the meibomian gland component there. And so, when we're looking at patients that come in for dry eye, if it's asymptomatic, we're seeing findings, starting with the treatments that you just mentioned, or if the patient comes in and has both mixed mechanism dry eye. So I'll do those treatments that I mentioned, but I will also come back and tell them to come back in 4 to 6 weeks. I will let them know, hey, you've lost 60% of your glands. This is what we're going to start with treatment. I'm going to recommend IPL, thermal pulsation, whatever it may be, to plant the seed, saying, hey, you're going to need it. We're going to talk more about this at the follow-up. And then at that time, I'll make that recommendation for the patient. Most of the time, the patient, it's all how we present it. Say, hey, this concerns me. This is what you need. If the patient says, if they agree, then they'll do it. If they say no, it's not no, never. They're eventually going to get it done, because we discussed with them their condition and what the sequelae is if it goes untreated for our patients.
Yeah, well, we're talking about treating MGD for routine patients to come in, but I find it to be extraordinarily helpful for certain patients. And we'll talk about contact lenses. Maybe you can talk to us a little bit about contact lenses in MG. Every year, 2 to 3 million patients stop wearing contact lenses. And the overwhelming reason why they stop wearing contact lenses is because of MGD. So for those optometrists or ophthalmologists who are fitting contact lenses, I think managing MD is really important, getting these patients comfortable with their contact lenses. What do you think?
Yeah, and so, I don't do contact lenses within our practice, but it is something that I do refer out to, what you mentioned, scleral lenses earlier, for patients, because we know that's a great therapeutic option for patients with dry eye disease and MGD. But if there's a contact lens patient, we know from the several studies that I showed earlier that MGD is prevalent in the contact lens patient. And so going back to if it's a new fit, making sure, do they have a healthy ocular system? Do they have healthy lids to promote successful contact lens wear? Or when we're refitting those patients, doing the same thing. One of the things I'd recommend for a contact lens wearers overall is going back to some of those stage 1 treatments that you mentioned. There are lipid-based tiers that are compatible with contact lenses that you can use, and Sustained Complete comes to mind. For those patients, the nutraceuticals, we know that there's several on the market. You mentioned some of the products already, and so that works on the dryness from the inside. But doing that heat, when they go to the dentist tells them to floss. I'm going to tell them to do the heat. I'll tell them to do potato, but they need to do something to help optimize that ocular surface.
Yeah, that's good. That's great. And then you don't fit contact lenses. I know that you refer them out, but I know you co-manage cataract surgery. And as a cataract surgeon myself, I would have to say that one of the greatest aspects about co-managing with some of my referring optometrists and ophthalmologists is if they can manage MGD before the patient gets to my practice, it makes everything go so much more smoothly, because the key to a good surgical result is nailing the intraocular lens. And we know from prior experience that if you have MGD, your tear film is of poor quality, and your keratometry is not going to give you an accurate IOL biometry. So managing dry eye, specifically MGD, as well as aqueous deficiency, really helps us hit the target. And when I talk to my referring optometrists in my practice, we talk about this constantly. You have one of the busiest surgical practices in the area. What do you tell optometrists who refer to your surgeons about managing MGD?
Yeah, so we tell them first, we identify before the surgery, it's the patient's problem. We identify after the surgery, it's that gift that keeps on giving. And we've all had that patient within our practice. In the age of, with the presbyopic IOLs, or the advanced technology IOLs, in the earlier days, we had patients at an OD. And communication is the key to successful collaboration. And one of our referring ODs says, "Hey, well, we did this multifocal IOL, 20 patients, half of them love it, half of them can tolerate it or don't like it at all. We got to figure out what those 10 patients, what was the issue, and it ended up being dry eye. Underlying result was going to be MGD for the patient." And so going back to what you mentioned, we need to optimize that surface. What we discuss with our referring providers is we let them know, hey, these are your patients, and let them and treat them accordingly. I mentioned the Gupta study. I mentioned Trattler's study. Actually, Liz Yu, her and Cecilia Kenning, they published a paper, I think it was last year, looking at the prevalence of MGD atrophy, meibomian atrophy, at a cataract evaluation. And they had like 395 patients on there. And about 95% of those patients had grade 1 atrophy or higher. And so it's there. And if there's atrophy, there's something going on in those glands, and so express those. But we challenge them and let them know, hey, these are your patients. Identify it before surgery, treat them, let them know the importance of optimizing that surface to get them the best visual outcomes. And if they tell that to the patient, this is why we're prescribing the heat, this is why we're doing thermal pulsation to optimize those outcomes, then the patients are going to say, yeah, well, if that's what we're doing to get me the best outcomes. Or does the patient really want poor outcomes? No one wants that. You know, so in our practice, so some of my partners, so everyone identifies MGD and dry eye. And so we have the protocol in place, as I mentioned, we all do the speed questionnaire. But one thing that we know that not every surgeon loves dry eye disease. They love to do surgery, they love to do cataracts. And so some of my partners, Liz, Yu, John Shepard, they're all identifying the cataract. They're going to treat the dry eye prior to the surgery if needed. But then some of my other partners as well, they love to do cataract surgery. They'll recognize the dry eye, but they don't want to treat the dry eye. And so what they'll do is they'll do the handoff, and so Steve Scoper will bring me in and say, hey, I want to introduce you to Dr. Whitley. He's going to address the dry eye. Once he says you're ready for surgery, then I'm happy to do surgery on you. And so we have those protocols. And so having that discussion internally, if you work in a collaborative practice, ODMD practice, or have that conversation with your referring doctors just to make sure everybody's on the same page to get the patients the best outcomes. How do you do in your clinic? Because you all have a busy clinic as well, and not everybody does dry eye, as we know.
No, not everyone does, but we try to tell our referring doctors how important it is, and they understand that. MGD is really the linchpin to improving your result. And it doesn't only apply to just contact lenses. It doesn't only just apply to cataract surgery. It also applies to LASIK and corneal refractive surgery as well. It's almost everything we do surgically is improved by managing dry eye. So once a doctor understands the value of improving the tear film, I think they become much more readily agreeable to treating these patients more aggressively. I can't overestimate how important it is to treat this disease. And once you do this and you see the results improve markedly, it really changes your approach to managing patients on a routine basis. And these patients are arguably the most happy patients in our practice. The most common patient who comes into us with meibomian gland dysfunction has seen 3 to 5 doctors previously. No one has ever paid attention to it. They've kind of ignored it and they've moved on to other things. And when you pay attention to this very common prevalent disease and talk to the patient about it, the first visit may be a little longer, but after that, they become very fast. These patients are extraordinarily receptive to hearing about it. They respond well, and they become ambassadors for your practice, that you're the one that actually spent time talking to them about that. So I want to say thank you to everyone who joined us here today for this MedNet recording. On behalf of Walt Whitley and myself, Eric Donenfeld, I want to thank you for joining us for real-world evidence and emerging treatments for meibomian gland dysfunction. And we hope you enjoyed the time you spent with us today. Walt, any parting comments from you?
Thank you all very much for being here, and it was a pleasure presenting with you once again, Eric.
Our pleasure. Everyone have a good day.
Thank you.